Good evening to everybody, dear colleagues, dear friends. Welcome once again to this ESGE webinar. This evening we will talk about enteroscopy, especially therapeutic enteroscopy. We have two super experts, both for device-assisted enteroscopy, namely Dr. Despott from London. I'm Marco Pennazio from Torino, Italy. And then we will talk about motorized spiral enteroscopy with Dr. Torsten Beyna for Düsseldorf. You know that the small bowel has opened its box after the advent of capsule endoscopy in 2001, and a few years later, enteroscopy became available and changes completely our clinical practice managing small bowel disorders, because in the past, the surgeon has had a very important role. Nowadays, we can treat the majority of lesions endoscopically or use this technology for more precise surgery. So you know that for the 4 consecutive years, ESGE offers you this opportunity to view high-quality presentation on hot endoscopy topics from world leaders in endoscopy all over the world. We have also the possibility to interact with speakers and to participate by submitting online questions. You can use the question and answer tool at the bottom of your screen. And you also have the opportunity to receive CME credits after the webinar, and we will inform you how to do that. And without losing any time, it is very great pleasure for me to introduce a very deep expert in this technology at Despott. We will celebrate 20 years of double balloon enteroscopy. Edward works in London and is a very great experience in this field. Welcome, Edward. It's up to you now to show us how enteroscopy device-assisted works. Thank you very much.
Thank you so much, Marco. That's a really kind introduction, and it is a great honor and a pleasure for me to be here today talking to you at this webinar organized by our great society on enteroscopy. So my task is to talk you through the 20 years of double balloon enteroscopy and show you why it is here to stay and that it is very safe and effective. These are my disclosures. So it is a very exciting year, notwithstanding all the setbacks of COVID. Let's forget about COVID for the time being. We are celebrating 20 years of a phenomenal technology that has really allowed us to dive deep into the small bowel effectively and safely. Because although for Stanley Kubrick, 2001 was a space odyssey, for us endoscopists, 2001 was a small bowel odyssey. Why? 2001 saw the birth of capsule endoscopy and double balloon enteroscopy. And if you were to look at the timeline in terms of small bowel endoscopy, it is more akin to a space exploration timeline with lots of failed devices and things that could do great harm. This is intraoperative enteroscopy, a case of bowels out with lots of morbidity and potential mortality. And an example is push enteroscopy, which although gets you a distance many a time, just stretches the bowel and gets you nowhere. And this was the seminal paper by my good friend and dear mentor, Hiro Yamamoto, when he published this prototype concept of total enteroscopy with a non-surgical steerable double balloon method. And it revolutionized things. And it is simple but genius, really simple but genius. With 2 small latex balloons, you're able to create anchor points. With both balloons inflated, when you pull back, you shorten the bowel. So with a 2-meter long enteroscope, you're able to scope the whole of the small bowel. And its incorporated overtube means that with the overtube balloon inflated, any movement of the enteroscope is converted to effective movement rather than stretching of the bowel. Simple but genius, very much in the vein of Hiro Yamamoto himself. And he's here with his prototype, and this is at the launch. And I am very fortunate to have fostered a very, very fond and deep relationship with Hiro Yamamoto. He's like a second father to me, and we also extended this relationship to both our institutions, whereby his senior colleagues come over and spend several months with us at all free, and we go over to them. And this is him at our institution. And of course, he's always our very special guest star at the Advanced Endoscopy Masterclass, the International AM London, which we hope to welcome you to again in 2022, pandemic allowing. In parallel to the developments of double balloon enteroscopy, of course, there was capsule working its way, and capsule is a very good tool and minimally invasive, but we have to admit that it is a scout. It takes pictures but can do not much else, and that's its limitation. But it is a good scout. It allows us to be guided as to the route of approach. For example, as shown in this old paper by Gay et al., we can pick the route of approach either through the mouth or through the bottom in order to reach the lesion. And over the years, of course, there have been further developments, so the resolution has improved. And the latest kid on the block for capsule is artificial intelligence, which has improved reading speeds down to 6 minutes with tremendous sensitivity and specificity, which very much are superior to us human readers. And in parallel to that, of course, we've seen developments in dedicated cross-section imaging. You can see this image from a CT angiogram, which also complements. And so these technologies are complementary mainly to the flagship, which is double balloon enteroscopy, which allows for direct evaluation, biopsies, which are so important in some circumstances, endotherapy and the vast area of it, which we'll talk to you about in a minute, and of course marking for further minimally invasive care for laparoscopy. And biopsies can be very important. So this was a patient who presented with small bowel symptoms, obstructive symptoms, with a CT scan showing a thickened small bowel. They tried to reach it with single balloon enteroscopy and failed, and he was sent for surgery because they were certain that it was something that needed surgery. He came to me for a double balloon enteroscopy. I biopsied it, and lo and behold, it was a lymphoma. So it has saved a patient an operation, and we see this often. It has an established role. Of course, after 20 years of experience and over 1,450 papers on double balloon enteroscopy, we know that it has really revolutionized the investigation and management of small bowel pathology, not just for evaluation and biopsies, but also for the treatment of midgut bleeding, strictures, polyposis syndromes, foreign body retrieval, for example, retrieval of a capsule, of course, as a guide to minimally invasive surgery, laparoscopy with a tattoo, and endoscopic access to altered anatomy, which is getting more frequent in the world of bariatrics. It is also highly, highly effective for technically challenging colonoscopy, allowing 100% completion even in previously failed colonoscopies, which would have failed in expert hands. So it is a really, really good tool. Greater expertise in dedicated centers allows for faster and safer enteroscopy. So for example, in our center, together with my good friend and colleague Alberto Moreno, we run between 4 and 8 double balloon enteroscopies a week. The average time, we've looked at our database, is just 45 minutes or even less sometimes, with complication rates which are exceedingly low. In our center, we barely ever see pancreatitis, for example, which, as an aside, can be associated with very long procedures. So over 2 hours is a big no-no. So long procedures are the thing that may lead to pancreatitis. And of course, we hit the target in over 90% of cases. So if you hone down the expertise, it is a fantastic tool, which is fast, safe, and effective. And safety, of course, has been mirrored in the meta-analysis done in the first decade by ESGE et al. And the overall, including diagnostics and therapeutics pooled complication rate, was less than 1%. So very, very safe. Effective, as you will see, in various scenarios. So it does what it says on the tin in the right hands. And of course, we also learned importantly that in the case of small bowel bleeding, which is the commonest referral reason, timing of the investigation, as shown by my good friend and our chairperson Marco, is critical. And it is safe and effective even under extreme conditions. So this is one of our cases that made it to the pages of National Geographic. We were fortunate to have the team visiting us at the height of the first wave of the pandemic. And this was a case of a patient in his 50s on the intensive care unit with severe COVID-19, with ongoing active bleeding from the small bowel. And as if that were not enough, he had a hemoglobin of 35 grams per liter, but refused transfusion due to religious reasons. So we went down on the emergency, as an emergency double balloon on the intensive care unit, and achieved hemostasis from a bleeding small bowel diverticulum. He has made a full recovery and was discharged home, and he still hasn't bled. And I've called him even about a week ago. So this is a great success story, which I think showcases how effective and safe this device is. And the evidence, of course, has supported the production of our great guideline led by Marco Pennazio. This is the clinical guideline, which is due for review because it was published in 2015, but still holds a lot of what we already know and still know about these technologies, mirrored by the technical review, also involving Marco as senior author and our good friend Emanuele Rondonoti. And of course, performance measures led by our good friend Cristiano, creating benchmarks for how to best do these techniques and technologies and procedures, and then writing the curriculum for our future generations to learn it safely and effectively. Of course, through the years, as with anything else, you see competing technologies. So single balloon came first, which was an offshoot of double balloon, missing a balloon. Then spiral enteroscopy came around at the hands of Paul Ackerman in 2007, initially manual, and then that went paused for a while the latest thing was being developed. And balloon guided was designed by Naviade and then taken over by Pentax, and this allows you to go deeper than push enteroscopy, but of course there are doubts as to whether it takes you as deep as dedicated technologies. And of course Torsten will talk to you about power spiral a bit later. But double balloon enteroscopy set the gold standard and arguably is still the gold standard and shall remain so because of its safety. So there is no risk of it getting stuck anywhere in the gut. All you do is deflate the balloons and take it out quickly. There are no real issues about the device causing harm itself. In fact, complications in the context of diagnostics are almost unheard of. And of course, it is still safe and effective even in the context of multiple adhesive disease post-surgery, which one has to consider is a huge chunk of our patients. And this highlights the example here that I'm showing you. So we're down from the mouth into the ascending colon in less than an hour in a patient with adhesive disease. And sadly, this patient had small bowel obstruction, secondly to a partially deflated bariatric balloon which had migrated into her ileum. We couldn't go up from the bottom end, of course, because she was obstructed and couldn't take prep. And to save her an operation, we went down throughout the whole of the small bowel and pushed this balloon into the ascending colon, and that's it retrieved. So this highlights the safety and how it works in every circumstance. Of course, we've seen technological enhancements of the scope itself with a super CCD chip with fantastic images, but also with the processor, with the balloon pump, which allows for inflation and deflation of the balloons in a much more rapid sequence, and plus accurate handling and a wider working channel of 3.2. And what have we learned from the evidence, I hear you ask me? So even from the first decade, as published by ESGE et al., where they looked at over 12,800 procedures, there was already an excellent diagnostic yield or pool detection rate hovering around the 70% mark. And in some centers, this is even higher than that now, with high and respectable pan-enteroscopy rates of about 44%. And I step aside and say, it is very rarely required in clinical practice. So it should never be our real goal. The goal should be to hit the target. So pan-enteroscopy is an aside. It is very rarely required in real clinical practice. Going on to complications, less than 1%, and of course mortality almost unheard of. What about specific scenarios? Bleeding is the commonest one, effective at reducing blood transfusions, iron therapy requirements. Of course, we know that these patients tend to rebleed because of the underlying nature of angioectasias, which are the commonest driver in the Western world. But we know also that repeat endotherapy reduces the risk of rebleeding, reduces the need for intervention, and we should keep doing it, okay? Timing, as shown by Marco and colleagues, is key. The sooner you hit it, the better. And this is an illustration of the technique. So with APC, use a non-contact technique to reduce the risk of thermal injury to deeper components of the small bowel. Use a low wattage and a low voltage so that you won't insufflate the bowel too much. And we also know that when we have pulsatile lesions, clips are more effective. Okay, this is a Dieulafoy or Dieulafoy in the jejunum, and a clip is applied to staunch it and stop it bleeding. And in order to guide you, our colleagues from GC Medical University, Professor Yano and Yamamoto, came up with their classification. So when you have pulsatile lesions, it is better to clip. A tip again, non-contact APC, use low power, maximum 25 watts, use low argon flow rates to reduce the risk of insufflating that small bowel too much, and consider saline lift to reduce thermal injury and clip pulsatile lesions. What about strictures? I hear you ask me. It is very effective, okay, and it can save patients' operations. As shown by Hirai from Japan, both in his large study and also in the meta-analysis, clinical efficacy is over 87%, with surgery-free rates, meaning avoidance of operations, still highly respectable even at 3 years, over 73%. We know that redilatation is required, but that is a much smaller price to pay than surgery, which has a higher risk, and the perforation rates are also acceptable. And this is us doing it, so I'm taking biopsies as requested by the referring team. This can be done with fluoro or without, depending on the circumstance. I advise fluoro if it's angulated. And the trick is to look through the balloon to make sure that you can see what you're dilating. And this is a through the scope balloon made by Boston Scientific, which allows very good views to be seen through the CRE balloon. So stick to the 5 centimeter rule, because longer strictures are less amenable. They won't have the right outcome. Fibrotic rather than inflamed, straight, and consider using the cast hood, which is also designed by our GC medical colleagues, Professor Yano and colleagues. And this has calibrations to allow you to choose the balloon and also facilitates multiple strictures without the risk of getting stuck. In Poitsia's syndrome, which is the main driver for polyposis in the small bowel, you know that PJS, although quite rare, thankfully, is a disease that really plagues the lives of these patients, mainly not through the cancers they get, because of course these are prone to getting breast, ovarian, and other cancers, pancreatic, but mainly because of these huge lesions that grow. And although benign, with almost a 0 risk of malignancy within those polyps, they cause intussusception. It is a tumor suppressor gene problem, as you know, which involves the STK11 or LKB1 mutation. It plagues these lives because these patients used to end up with multiple intussusceptions, surgery, adhesions causing obstructions, disaster. But with surveillance, so surveillance is done with capsule or MRI. It can be life-changing and reduces the risk of intussusception if we intervene with DBE or device-assisted enteroscopy to remove these polyps. In the past, we used to remove them, but I'll tell you a bit about the development. So this is an algorithm which I had designed with colleagues. Surveillance every 2 to 3 years, look out for the large polyps, and if you find large polyps, preempt the intervention before it becomes a big problem. Polypectomy, we call it now polypendotherapy, because although you will see that polypectomy is still done in some cases, it runs the risk of having issues, because these are vascular structures that can bleed significantly during the procedure, and they tend to draw in the muscularis propria into the stalk. Remember, these are hematomas, knots of funny tissue, so they can pull. And if you cut even close to the head, you can end up with a perforation. So when we're resecting such monsters, many a time we have a laparoscope ready on hand, because that can result in a perforation. So our colleagues from GC, Professor Yamamoto et al., have come up with the idea of ligation leading to auto-amputation. Okay, remember that the risk of these polyps harboring anything serious is low. So if you tie them off and you watch them go ischemic, so this is an example using an endo loop here, the polyp is changing color already, it's become dusky, and it dies off. I always cut off the endo loop here just in case I have to intervene so that I prevent knotting. And Professiano designed the cross clip method, so in order to make it faster and even more effective, especially for the smaller ones, you can do a cross clip. So one clip is placed here, and then using a long distal attachment, you move the angle of the clip to a 90-degree angle, and like that, placing two clips at 90-degree angles will cause the blood supply to die, cut off, and auto-amputate without the need. And it's not just the PJS polyps that can intercept. This is a large flat adenoma, so a sessile adenoma, which resected with wide field DMR from the jejunum, and the patient has not had recurrence at DB. And this is a young patient who presented with similar symptoms, interception, and this was a huge ectopic stomach, ectopic gastric tissue, which we resected with wide VMR and avoided her an operation. We can also retrieve foreign bodies, of course, in the context of direct percutaneous endoscopic jejunostomy, up to 90% success rate, which is much higher than push enteroscopy. It facilitates the RCP and the treatment of bleeding in altered anatomy, and it's also a good guide for minimally invasive laparoscopic care. And this is an example where I went up into a hepatico-jejunostomy in the context of varices. You can see the bile ducts there, and this is our double balloon scope at the hepatico-jejunostomy, us injecting cyanacrylate glue. Remember that this patient did not have a ported vein, it was already occluded. This is the only context where I would put glue, and that's effective, and this was a success story. So what have we learned about the technique itself? We need a large room and we need a good team, so set up properly. This is my good colleague and ex-fellow Nico Lazaridis helping with this procedure, and an anesthetist delivering propofol. But many a time we do these without the need for propofol or general anesthetic. We can do this with sedation. About the technique itself, use the middle finger on the little wheel. It allows you to apply therapy precisely and also make your enteroscopy more rapid by finding the lumen quickly. Use saline immersion, so this is our flushing with the saline here, and use the designated distal attachment because that allows you to see the lumen by keeping you slightly away from the mucosa, and makes it more effective and safer. And also try to promote natural anti-clockwise looping. So this is us fishing out a capsule from 6 meters down, and you can see the anti-clockwise loop. And you say, why anti-clockwise? Because in nature, many a time, the looping is anti-clockwise following the Fibonacci principle. And this is also shown in embryology. When the gut returns to the body after herniation into the umbilicus to develop, it goes back in with an anti-clockwise loop. So this is why it is favorable to try to apply anti-clockwise looping. And this is, of course, taught to me by Professor Yamamoto himself. You need to try to encourage that anti-clockwise looping by keeping the scope on the left, and I do it both on insertion and even on withdrawal. And this is the promotion for deeper insertion. So in the insertion phase, advance the scope with minimal pressure to minimize trauma or pushing the overtube back, minimize insufflation, better still use saline immersion to prevent water intoxication if you are using submersion. Arrange the shape of the intestines to simplify and create those anti-clockwise loops, and do this also on the shortening phase, and advance the scope with reduced angulation, so keep the lumen in view. During the shortening phase, meaning the pullback, during the anterograde, do not shorten before you reach the jejunum, otherwise you fall back into the stomach. And in the retrograde, do not shorten within the terminal ileum because you fall back into the cecum. Arrange the shape to create those anti-clockwise favorable loops and reduce angulation. Keep the lumen in view all the time. A key question here, how do we insert through the terminal ileum deeply? So aspirate excessive gas, use immersion techniques better, keep the valve at 6 to 9 o'clock, change the angle of the ileocecal valve to favorably by allowing the cecum to be straightened by pulling back with the balloon inflated in the ascending colon. And this is a video showing just that. And if you are going to use the immersion technique, if the patient is in the supine position, it will also gauge how well you're doing in terms of creating those favorable anti-clockwise loops. Because if the fluid level is on the left-hand side, you're creating those loops that are favorable. If it's on the right, you are creating these unfavorable swan necks or S shapes. Of course, there are techniques which we had looked at and I had published many years ago on how to deal with adhesions. It's mainly skipping a pullback and how to deal with a really stubborn retroverted valve. You can retroflex and enter forward. So I encourage you to read those. And of course, changing position like in colonoscopy can help. And in the context of adhesions, counter pressure, or in the setting of hernias, counter pressure can also help you go deeper. And everything is explained for the reading in our guidelines from our great society. So in summary, Marco, ladies and gentlemen, friends and colleagues, Torsten, I hope I've shown you that double balloon enteroscopy is a firmly established pillar of minimally invasive care. It is very, very safe and effective, and for all these reasons, it is certainly going nowhere. It is very much here to stay. Thank you. And I would like to invite you to our masterclass, hopefully in 2022, and I'd like to thank my team, especially Alberto Moreno. Thank you.
Thank you, Edward. Thank you for your fantastic and enthusiastic overview about enteroscopy. And now we have to move a little bit with another. We have to celebrate another anniversary. 5 years of motorized spiral enteroscopy. We have the best expert in the world with this device. And okay, it's up to you now, Torsten, to show us that motorized enteroscopy may compete very efficiently with double balloon enteroscopy.
Okay, so we have to celebrate 5 years of motorized spiral enteroscopy, and we have the principle of a self-propelling endoscope. You have seen in Ed's presentation the different principles of deep enteroscopy. So we started with the balloon technique, with double balloon technique in 2001. And in 2008, Paul Akerman and his group introduced for the first time the spiral enteroscopy, the manual spiral that depends on a different principle by transforming rotational energy of this spiral overtube into longitudinal movement of your enteroscope in reference to the small bowel wall. So to make a long story short, we then performed the first case of the novel power spiral enteroscopy. That was a result of a great performance of the engineers that developed this motorized version of the spiral enteroscopy. It was done in November 2015 in our unit in the EWK Düsseldorf for the first time. And for the ones that don't know the new scope, I would like to show you a short video. Maybe you have already seen it. So we have an integrated electric motor in this endoscope that is more or less like a pediatric colonoscope. We have this short spiral overtube with soft spiral fins that are bounded to its exterior, and this short spiral overtube is then backloaded onto the insertion tube portion of this endoscope. And is connected to a rotation coupler that is located 40 centimeters proximal of the endoscope's tip. And this can then be used to pleat or unpleat the small bowel onto or from the scope, depending on the direction of rotation, clockwise or counterclockwise. And this can be activated by a foot pedal switch. So we then started the first trial, two study sites, European centers, EWK Düsseldorf and the Erasmus University in Brussels. This study was done only on antegrade enteroscopy. Power spiral enteroscopy was done in 132 cases. The primary objective of this trial was diagnostic yield in the patients with suspected small bowel diseases. And so the results were quite impressive. The insertion depth was median 450 centimeters beyond ligament trials in mean 28 minutes. And as you can see, the range was 0 to 600, and 600 was the insertion depth that we defined to be a total antegrade enteroscopy with passing the ileocecal valve from the antegrade approach, and this was possible in more than 10% of the cases, keeping in mind that the diagnostic yield was the primary endpoint, and if we found a certain diagnosis, then we stopped and didn't insist on total enteroscopy, so this was most probably underestimated. In terms of the primary endpoint, we had an analysis. The diagnostic yield overall was 74%. Remarkably, it was highest for the ones that had the previous indeterminate finding in MRI was 80%, and was least with 52% for the ones that had previously inflammatory lesions of polyps in the video capsule endoscopy. So by intent, and this was sometimes criticized, but I think it was the best way to go, was not to include a control group in the first trial, as we also included the first in human case as well as the learning curve cases into this first trial. So we then decided to at least compare our results to the best available data, and this was at this moment this meta-analysis that gave pooled results about the diagnostic yield of balloon enteroscopy compared to spiral enteroscopy, for randomized controlled trials, and they found a diagnostic yield of 48%. So although this is statistically maybe not completely appropriate, we can at least speculate that our results are not inferior to these results. So to show that motorized spiral is an interventional procedure as well, you can see almost 2/3 of the procedures were interventional, with all kinds of interventions, including EMR or removal of video capsule, and most of the cases were for bleeding cases with APC clipping and so on. Remarkably, 100% success rate, so all of these interventions were successfully performed. We analyzed the learning curve as well, so we divided our group into quartiles and compared these quartiles, so we didn't find any significant differences in between the first and the fourth quartile in terms of the diagnostic and therapeutic yield, success rates, procedural time, depth of maximum insertion, total antegrade enteroscopy rate, as well as adverse events. So if we talk about adverse events, and Edward started this discussion already, we had in this first trial a rate of serious adverse events of 1.5%. So there was only one delayed perforation that became clinically apparent 48 hours after power spiral with APC. So we are not clear whether this is attributable to power spiral itself or to the APC therapy. It was needed laparoscopic suturing, and one more that was bleeding requiring blood transfusion and endoscopic clipping. This was a laceration of the G junction after spiral enteroscopy. So some questions remained after the first trial. So we all wanted to know, encouraged by these results, how deep can we really go into the small bowel using power spiral? And as we all know that total enteroscopy is mainly achieved not only antegrade, but in a bidirectional approach. What is the true efficacy of power spiral for total enteroscopy? And this implicates a second question: what's the efficacy of power spiral from the retrograde approach? We all know that manual spiral enteroscopy was, frankly speaking, not effective from the retrograde approach. So this is why we then contemplated another prospective trial, again, the 2 study sites. This time we performed enteroscopy with the primary aim to achieve a total enteroscopy. We included patients with indication for complete enteroscopy. We started with antegrade and then we went to retrograde if antegrade was incomplete. These were the results. So we found an overall total enteroscopy rate in this group of patients that didn't have any previous surgery, major surgery, of 70%. So 16.6% were completed from the antegrade approach, and additionally 53.4% were completed from retrograde. So obviously high rate of total enteroscopy. And Ed also mentioned this large meta-analysis that has been done after the first decade of double balloon enteroscopy, including more than 12,000 patients. And if we compare our results from this first trial to what we know from this meta-analysis, we can see rate of total enteroscopy for manuals for power spiral 70% versus 44% from this meta-analysis for double balloon. However, Ed already mentioned that total enteroscopy is not needed in every case. And if we have a certain look onto the total, the complete antegrade enteroscopy, it was tenfold higher in our group, 16.7 versus 1.6% in this meta-analysis. Power spiral seems also to be superior to manual spiral, especially in terms of retrograde enteroscopy, which was 100% technically successful in our trial. In terms of safety, there were in this trial no major adverse events. There were only mild adverse events that were in most of the cases clinically asymptomatic. However, we had the limitations that we had no patients included after major abdominal surgery, and especially patients with altered anatomy in this trial. So in the meantime, there was more evidence coming from India. My friend Mohan Ramchandani published this retrospective trial, more than 60 cases from the AIG, from Hyderabad, technical success rate 93%, diagnostic yield 70%, total enteroscopy rate 60%, remarkably 31% complete from antegrade. That might be caused by the different Indian population compared to the West European population, and in terms of procedural duration and insertion depth, it supports our results from our first two trials. Before we go now further to use power spiral in altered anatomy and ESCP, I would just like to mention that in the meantime, we completed another prospective European multi-center trial. I cannot talk about the results in detail, but as I've seen that some of the investigators of this trial are also participating today. So I would just like to mention that we have good results, and so power spiral seems to be effective and safe also in this group of patients after major surgery and after in patients with altered anatomy. So let's go further, because a lot of people ask me, what about power spiral for ESCP and in altered anatomy? So in this context, we published the first case of power spiral in a patient with altered anatomy after Roux-en-Y reconstructive surgery and bilioenteric anastomosis last year. So in the meantime, we conducted more cases. We're going to submit this in the next days. However, I would like to show you the data that we have. My colleague Markus Schneider presented this as an abstract during the ESGE days already. So we had 36 patients. Most of them had biliary indication. So most of them had Roux-en-Y reconstruction. Only 6 had Birath 2 reconstruction. As you can see, technical success, we divided up into enteroscopy, cannulation, and interventions. So enteroscopy was reaching the papilla or the anastomosis respectively was 86%, cannulation success 83.9%, and then all interventions could be performed. However, the most important question is, what's the overall motorized spiral enteroscopy ESCP success rate, including all these different objectives, and this was 72.2%. Mean procedure time 69 minutes, and adverse event rate was 5.6. There was one major adverse event. We had a delayed post-sphincterotomy bleeding that occurred 48 hours after sphincterotomy and after restart of oral anticoagulation that needed surgery. However, the rest, nothing happened at the anastomosis and so on. So I would like to sum up. In my view, motorized spiral enteroscopy is the future. It represents a disruptive new technology. It's the first active endoscope that has been evaluated or is being evaluated in these large prospective clinical trials. It's safe and effective as far as we know for deep enteroscopy from antegrade as well as from retrograde. First data is now available for post-surgical and altered anatomy patients. We have first data on power spiral assisted ESCP, and I think power spiral has the potential to change the diagnostic and therapeutic algorithm to small bowel disease in the near future. However, I agree that there are a couple of indications we have not enough data, and I'm still convinced that double balloon is here to stay. However, the future will tell which role motorized spiral endoscopy will take in this situations, and we still need careful further evaluation, especially in comparative trials and especially in also in patients with altered anatomy and for biliopancreatic interventions. So I now prepared some cases I would like to show you because currently you only have data. So some of you might already have seen this case. It's a male patient, 49 years old, that had recurrent episodes of diarrhea with flush. So he was previously diagnosed with a microadenoma of the pituitary gland without endocrine activity. So EGD colonoscopy showed no pathological findings. However, CT scan, abdomen, thorax without pathological findings. And then this was performed, gallium dotatate PET CT scan that showed enhancement in the right lower quadrant, and video capsule endoscopy showed this. And so we performed the power spiral enteroscopy from the antegrade approach. As you can see, we did this in this patient. We started from antegrade. However, this enhancement was quite deep in the small bowel. So what I want to show you is that sometimes when you need to go really deep, you need some assistance from outside to mobilize the small bowel, like Ute does in this case. So we then reach this area. You have a very stable position of the enteroscope because of the spiral technology. Can easily see this subepithelial tumor. Usually we don't biopsy these kind of tumors, but in this case I did and caused some bleeding, and then you have a very stable position then to perform your endotherapy and to also inject a tattoo for marking this lesion for the surgeon. So in the end, this was a nice case showing a neuroendocrine tumor, and this patient was then, the treatment was surgical and it was curatively resected. So I want to show you another case, a female patient, 56-year-old, and MRI showed, so new onset of recurrent epigastric pain, EGD colonoscopy without pathological finding, transabdominal ultrasound showed a thickening of the small bowel wall. Fecal calprotectin was elevated, as you can see. So MRI showed this enhancement as well as a stricture. And then we performed power spiral because double balloon in this case, however, I think Ed was not the one who did this, was not able to reach the region of interest. And as we are running a little bit out of time, I would go a little bit further. So we started power spiral and then went through it relatively quick. As you can see in these situations, normally when you're in the upper jejunum, you just, after passing the ligament of Treitz, you activate forward rotation, then usually it goes relatively quick to pass the first 1 or 2 or 3 meters of the small bowel. So I jump a little bit forward that you can see what happened here. So we could see this stricture. So I don't know if some of you already can guess what it is. However, you can see it's not like an IBD. So Then we've also find here this video capsule that was retained in this stricture. And so we now could use the net to remove this capsule. So to make the long story short, we found histopathology showed a diffuse large B-cell lymphoma. And so there was, this patient was treated using chemotherapy and immunotherapy. So as we already have seen very nice cases that presented with double balloon in Peutz-Jeghers patients, treatment of these polyps, very nice using endoloop and clipping technique. I just wanted to show you how we can use power spiral to perform this therapy. In this patient that has been treated by my chief, Horst Neuhaus, in I think during EndoLife Roma, I think some years ago. So it was very nice that he found this large polyp in the middle of the small bowel, and then because you have a very stable position using power spiral, you keep the spiral not moving, and so you have a stable position and can apply therapy that you know from colonoscopy, because the scope stays in position. You have a large working channel of 3.2 millimeters. You have an additional separate dedicated irrigation channel that is quite helpful when you have to clear your field of view, and also to treat these kinds of bleedings. You can just irrigate, and then as you have seen, to prevent delayed perforation or bleeding, you can just place a clip here. Yeah, maybe we can in a minute discuss how to approach these large polyps in the future. And then I would just switch to the last case. I've already showed to you this first case of power spiral assisted ESCP in a patient after duodenum preserving pancreatic head resection and bilioenteric anastomosis. So MRI showed this stricture, and then I can show you how we approach this using power spiral. The first step is always to pass the upper GI tract, to pass the pylorus, and then you have to go through the pylorus and the ligament of Treitz with a spiral. So at this point, you need to push your power spiral enteroscope, although usually you can just let the spiral rotate and pleat the small bowel. At this point, you need to push because the spiral has to engage the pylorus and talk through the pylorus. So you need some pushing force, and you can see that looping occurs in the stomach. You can see active forward movement of the tip of the scope. However, you are still in this loop position within the stomach. And at this point, I usually keep forward rotation active, but pull back the scope and straighten the position of the endoscope. This is the spiral that is now in the small bowel and now beyond ligament of Treitz, as Ed already mentioned. So try to have counterclockwise looping that is also effective in power spiral. So then we have to find the Roux-en-Y anastomosis. So just save some time. I jump a little bit forward. You can see how effective this pleating of the bowel is as well in these patients, in these post-surgical patients. Then you identify the hepatobiliary limb. So, and then I try to jump a little bit forward within the video, which is not possible now. And here we go. And now you can see, just keep spiral rotation active, and then the spiral will be self-propelling to the bilioenteric anastomosis. I jump a little bit forward to save some time, and then I use always a short transparent hood for these ESCP cases to keep a little distance to the anastomosis, and then you can use your standard instruments, standard length instruments that you can use during your standard ESCP cases because you have a short length of 168 centimeters and a diameter of 3.2 millimeters then to apply this therapy. So this was then the clinical follow-up. So after balloon dilatation, the jaundice resolved within 48 hours. So I'm also very happy to invite you next year to our Düsseldorf International Endoscopy Symposium in February, but I will now open the floor again to Marco and Ed for some minutes of discussion. I'm looking forward to your questions.
Thank you, Torsten. Thank you both for the clarity of your presentations, for the important information you provide us. Now it's time for a brief discussion. We have some questions from the audience. We have some important people attending this session. First of all, Professor Sirsema, that is asking you, maybe to Edouard, what are the differences in outcome comparing double balloon enteroscopy and single balloon enteroscopy? And maybe for Torsten, how many procedures are required for learning power spiral enteroscopy? What is the learning curve for this new procedure?
Thank you, Marco, and thank you, Torsten, for a lovely presentation. I return the compliment, especially for your stable endotherapy. Coming to double balloon versus single balloon, there were no real outcome differences in terms of diagnostic yield or therapeutic yield in the studies shown. Now, as to whether these were powered high enough or whether it was too a fine difference to tease out, that's that. Anecdotally, in the community, we all know that if we were to choose a tool to dive deep from the balloon assisted aspects, we all will go for double balloon. That's the bottom line, really. So although it's not been shown in the studies, it's in the real world that is the case.
Torsten?
Yeah, and yeah, concerning my question, the learning curve, that's a really good question. However, we tried to approach this question in our first trial. So, and we had some recommendations by the experts in the field. So before we started this first trial, we thought 10 to 20 cases would be a good threshold for learning this type of procedures. And then we conducted this European multi-center trial and we went into the detail, and we found that in the first trial we didn't find any significant differences between the first quartile and the fourth quartile of our patients. And then in the trial that has not been published yet, we found that there's also a difference between the first 5 cases and the rest. So maybe it's somewhere between 5 and 10 cases to learn. I would always recommend to start with patients with normal anatomy without previous surgery. Then you can go maybe to post-surgical patients, and after that to altered anatomy. 5 to 10 cases.
One question for you, Torsten. So for performing a safe and effective motorized spiral enteroscopy, do we have to be expert endoscopists or also expert enteroscopists? Sorry.
Marco, this is a really good question. So from my experience, I would say you should be expert endoscopists. However, this system was conceived to make it effective and safe also in non-expert hands. However, we will see how this will work. And yeah, in terms of enteroscopy, I think because it's a different principle. If you have performed manual spiral, then this would be, I think, beneficial. However, if you are used to push and pull, then it might, so you have to adapt to a different kind of technique, that you let the spiral run and keep the enteroscope in the patient, do not pull and push. However, in my experience, these kind of maneuvers are also helpful during power spiral sometimes. So I think it's helpful if you have experience in enteroscopy as well.
Another question, Tom Morales, very well-known enteroscopist, asking Edouard, is fluoroscopy always mandatory advice for device-assisted enteroscopy? Do you use in which procedure? Always, never, every now and then?
Hi, Tom. Thank you. Thank you for this question. As you know, nowadays we very rarely use fluoroscopy in the standard technique. You know, we don't really need it at all, especially if we're doing it under immersion. As I told you, Professor Yamamoto discovered that if the fluid is on the left and the patient is in the supine position, you're creating those favorable anticlockwise loops. And if it's on the right, then of course you are unlikely to be created those favorable loops. So fluoro, for the technique itself, not needed. If you're going to dilate a complex stricture, that's a bit longer, or you've got adhesions, yes, use it. If you're going to do ERCP, of course you need it. So those are the three circumstances in clinical practice in my center, for sure, and I think this is reflected universally.
Thank you. Once again, another question about safety, which is very important. I mean, so there is a question from Dr. Wisdom Forward Mudombi about power spiral. Why does power spiral motorized enteroscopy lacerate the gastroesophageal junction? Are you concerned about that, Torsten?
Yeah, this is the result of this principle that we have rotation of this spiral, the diameter of this spiral. However, this within the GI tract, diameter of these spiral fins is 31 millimeters in total, and these spiral fins are soft, but 31 millimeter is quite high. So 80 millimeters is the stiff part of the overtube, and if you are not very careful, then this might happen. However, we see not many. We have not seen many perforations. To be honest, it was in the trials there was only one perforation, and this was a delayed one, not intraprocedural. And this was a patient that was on aspirin, and so this was the laceration of the G junctions. We didn't experience any severe lacerations or bleeding within the small bowel. Yeah, this might happen, but this goes back to the principle of spiral enteroscopy. It's just mechanics.
Some short technical questions. So for Torsten, do you still intubate all the patients with oral spiral enteroscopy? Because this is one major drawback, not drawback, but you have also to realize that for logistic reasons, sometimes it's not very easy to have all the patients intubated. What is the latest new about this?
To make it short, no. We intubate patients ASA3 and with special indications when we expect long procedures or something like this. All other patients are done with deep sedation using midazolam and propofol. In Germany, we're allowed to give propofol without anesthetist, so this is good situations that we have. By the way, all patients that we treated in this 36 group of patients with ERCP, all of them were done using deep sedation. No one was intubated. Okay, good.
A few questions about the technique that showed proposed by probably Dr. Yano, ischemic polypectomy, endoloop polypectomy. Do you use in every patient, Edwards? It's your frequent practice for every polyp in every, I mean, Pelsieger polyps, or no?
Yeah, we shifted gear until recently we were resecting these, and thankfully without many issues. But when we face really big ones and or where the stalk can pull the muscle into the stalk, the polyp can pull the muscle into the stalk, we can get perforations, as you saw. So we've elected to adopt this technique developed by our GC Medical University colleagues, and we apply it in every case now. It's very rare that we resect them and send them to the lab. We only do that if we're not sure what we're dealing with, because hamartomas occur sporadically as well, as you know, but we tie everything now. Okay. Marco, if I may, I want to intervene about safety.
Yeah.
So, Torsten, as you know, my main concern is safety, and I wouldn't be clean with my conscience if I don't speak about it here. So the main concern about spiral enteroscopy is safety, because although in the studies and in your hands, the safety profile seems to be acceptable, in the real world, these things are not really shown, you know, in the journals. And it can get stuck, okay, even in normal anatomy and even in normal patients. And when it can get stuck, it can give rise to really bad problems and perforation. So I think we need to highlight this, because it's good to look at the journals and the data, but we really need to highlight this. And it is also a black box warning when we look at spiral. So we have to really make sure that our readers or our audience understands this.
Yeah, but Marco, if you allow me, I would
very short, because there are other questions. But please.
So during our trials, we never experienced that our spiral got stuck in any patient. However, this, of course, this might occur, and this was why we conducted another prospective trial at 10 European centers, and the primary endpoint was safety, only safety, and we will report this as soon as possible. Yeah. However, we have to keep this in mind. Yeah, you're right.
Yes, I think
we don't have any large data.
I think we have to wait more data among because there are two different clinical evidence of more than 1,500 papers published in double bowel enteroscopy, and 10 papers about even less about. But as more evidence is accumulated, maybe we will see I think that it is a safe procedure, but in good hands for the time being. And there are two questions from Olena Kokubei. So, are operations in anamnesis contraindication for enteroscopy? If yes, which exactly, and how to select the patient at the beginning of practice? This is a question for both of you, because the majority of enteroscopy centers in the world use double or single balloon, but also for Torsten and also for Ed, what is the answer for you? Which is the best patient? How to select the patient for a safe procedure?
If I may start, so from my perspective, it's not a contraindication, but I would not start my enteroscopy service in these types of patients. So, but it's for sure not a contraindication.
Yes, I think it's true even for us. And when selecting patients for enteroscopy, you always have to bear in mind the holistic approach. You know, comorbidities and everything, and keeping safety in mind, pre-assess those patients and weigh the risk versus benefits, like everything else in medicine. If it's worth the risk, then of course do it carefully in the best possible scenarios, accepting that things may go wrong. But that should be the driver.
Maybe the last couple of questions, but there is a question from a colleague of mine, a friend of mine, Renato Santucci from Genoa, which is, if established for you as Edwards, the cutoff size of PJS polyps that oblige us to carefully remove the polyps with snare polypectomy or use the loop. You have a cutoff size to decide when to perform snare polypectomy or ischemic endoloop or clip polypectomy?
You're asking me? So yeah. I would always try to tie things off if I can, because the risk is lower, and we don't really need histopathology in these cases. Very rarely do they harbor any dysplasia, and even if there was dysplasia, it's very rarely going to become a cancer, and the polyp will die off. Okay. The cancers in the small bowel happen elsewhere, not in the polyps usually.
It's only me that I see cancer in a patient with a small bowel. But anyway, it's not so it's very infrequent, but you may also see adenomatous polyps in Pelizaeus syndrome. It's very rare anyway. One last question for you both about dilation of small bowel strictures, both with device-assisted enteroscopy and with motorized spiral enteroscopy. Are there any different applications to be used? Torsten first.
Yeah, maybe I can start. So, to be honest, we have no data on motorized spiral enteroscopy. So during our first trials, the severe stricture was also a contraindication. So I would be very careful. In the meantime, we discussed this before we went live. So in the meantime, I did some patients with dilating strictures and then passing after that with the spiral, but be very careful. I would not recommend to start because we have no data. We have some data with manual spiral. I think these patients should actually be treated if you have a couple of severe strictures, not with a spiral. Ed, what do you think?
I fully agree with you. There's a slight difference between manual and power. So with the manual, which I have a lot of experience with in the past, somehow you can dislodge it if it gets stuck. With this one, if it gets stuck, the safety mechanism prevents it from moving. It locks, it can't move. And trying to rotate will just twist the scope. So that is the main problem. So do not get stuck. Don't go through a stricture with a spiral, at least until we have more data or we create a deflatable spiral. Don't.
However, this safety mechanism is also an advantage because with the manual spiral, your assistant that wants to impress you always tries to
but you can
be
feel
quick
it,
and forceful with the spiral. So this might also prevent perforations.
Sorry.
Yeah, but you can feel it. You can feel it. We've never had real perforations with the device itself with the manual. You know, you can actually feel and you can dislodge. With this one, it's safety, of course, that built-in mechanism will create it to stop. And then you have a problem. And you don't want to get stuck in the middle of the small bowel. You don't.
Yeah.
No, you want to get stuck, especially deep in the bowel.
Right. I think that, okay, when you start with a new technology, you have to realize that everything is new. So, and especially for this new technology, which is completely different from double balloon enteroscopy or single balloon enteroscopy, maybe you have to know in detail how to perform this technology, because otherwise the risk of side effects can be quite tight or substantial. So I think that today, just to conclude, we have had the opportunity to learn a lot from two super experts, because the experience for Torsten with motorized spiral enteroscopy and from Eduard for double balloon enteroscopies was exceptional. We have learned a lot, especially not only the data, but also the tips and tricks on how to perform safely this very important procedure, because we have changed our clinical attitude, our clinical practice for managing this patient with special, sometimes very difficult disorders, which previously were managed only surgically with a very high complication rate. I thank you both of you, and I congratulate you both for this nice at the exceptional lecture. And for those who attended this meeting, this evening you will receive an email with the link to the CME survey in order to receive your credit certificate. And I also want to remind you that next year we will have the ESGE Days 2022, which is I can state for sure that this is one of the most important endoscopic conference all over the world. Save the date toward the end of April in Prague. Welcome you, and also I would like to remind you also the new benefits to become an ESGE members, not only to receive endoscopy, to participate of all the activities of the ESGE platforms, such as my ESGE tutors and the app for the quality. And also would like to invite you for next Wednesday for another symposium, the Fujifilm ESGE Satellite Symposium with from screening to treatment, evolving the upper GI quality toolkit from the chair Elisabetta Buscarini from Italy, Guido Manfredi, once again at Despott and Prate Bandari. And finally, I would like to thank the ESGE Governing Board, because allowed us to have this interesting webinar with you, and which wasn't being impossible with the help of our webinar team. First of all, David Inker and Gabriela Varga. Thank you very much to you both for those who attended this meeting, and hope to see you soon in the next webinar. Ciao from Italy, and see you soon. Bye-bye. Thank you.
Thank you. Bye-bye.